Hi, everybody. It's Mrs. Bartels. I'm going to get you going on a Chapter 7 lecture. Chapter 7 starts on page 68 of your book. It's called Understanding the Person, and it goes to page 77. Okay, you'll have a test on Chapter 7 and Chapter 9 this coming Friday. All right, so on Chapter 7, page 68, I'm going to go over to Schoology and pull up the slides for you guys. You can see here, there's the weekly plans when you log into Schoology. I'm going to go into my morning class. Okay. Go to materials. Let's go down to module 4. And chapter 7. Here we go. PowerPoints for chapter 7. I'm going to open them up so you guys can see them. Okay. Just the screen load for you guys. Okay, so chapter 7, Understanding the Person. Here we go. So this just tells you what the key terms are defining a person. So the first thing they talk about is that the person, meaning the patient or the client or the resident, is the number one priority. On page 68, it says the patient or resident is the most important person in the agency. So the patient comes first always. But you have to remember the patient is not just a person there with pneumonia or a person there with an appendectomy or a person there with cancer. They're whole. They're more than just a disease. So you have to remember that they are a person, an individual that is made up of many parts. So that concept or that belief is called holism. It's a concept that considers the whole person. It means that we don't think of a person as just the cancer patient or the heart attack man or the guy in room 212A. We have to remember they are a whole person. They're made of more than a room number, a name, or a diagnosis. So the whole person has physical, social, psychological, and spiritual parts. They are all woven together. So all those things make up a person, and you cannot really separate them, meaning like your physical aspects, if you are not feeling well, can affect your psychological aspects. So maybe you are experiencing a really bad headache. Okay, so it's a physical problem, but psychologically you're crabby and you're irritable because of the headache. So again, physical and psychological go together, social, spiritual, they all go together. You cannot separate them. They're all part of a person. So make sure you understand they cannot be separated. Each part relates and depends on the others. So here is a visual for you of what the 4 things are, how they link together like a chain of links. Okay. And that is on page 68 of your book. It says to consider only the person's part is to ignore the person's ability to think, make decisions, and interact with others. So don't think of them physically. You have to make sure that you understand that they're more than just a physical body with a disease. Okay, addressing the person on page 69. We talked about this already earlier in the year. How do we address people? You always go by their titles, Mr. and Mrs., Miss, Doctor. You never use nicknames like Grandpa or Papa, and you never use their first name unless they prove you to use their first name. Okay, so know how you properly address somebody. You properly address them using your titles because it shows dignity and respect. Never use their first name unless the person says you can. Okay, and don't use any other name or nickname unless they tell you it's okay. When we go on page 69, we're going to talk about the basic needs. Maslow is a famous research psychologist who says that a person needs these basic things to survive in life and to succeed in life. So basically he's saying a need is something necessary or desired to maintain life and mental well-being. So he is saying these things in the pyramid on page 69 are essential for people to survive and live. There's different stages that he talks about. The first stage is the physical stage, the physical needs. As you see, it's at the bottom part of the pyramid, and as you go up, things get smaller. So the base of the pyramid on page 69 is your physical needs. That includes your oxygen, your water, your food. And then your safety and security is the next level of the pyramid. That means that people need to know they feel safe, that they are out of harm and they're safe from danger. So they're not afraid. Okay, and then the next one is love and belonging. Some people become weaker or die from the lack of love and belonging. So it's important that person feels that they can relate and be loved and belong. Then they talk about self-esteem needs is the next level. The self-esteem needs. Self-esteem means to think well of yourself. People who often lack self-esteem will become ill, injured, older, disabled. So if you feel good about yourself, basically he's saying, and you have good self-esteem, you usually will take care of yourself. So, and then the top one is self-actualization, which is one that many people do not reach in their life. So let's look at it a little bit deeper here. So need is something necessary, desired for maintaining life and mental well-being. That's what Maslow is saying. Basic needs must be met for a person to survive and function, is what he said. Needs are arranged in order of importance. That's the pyramid I was just talking about. Lower levels have to be met before the higher levels are met. So here it says pyramid, okay? And as you can see, the lower levels of psychological needs, your air, your food, your water, your shelter, your clothing, your sleep. Then we go into people hitting self and safety and security needs, their property, a place to live, family, stability, then love and belonging, self-esteem, self-actualization. Okay. Self-actualization, again, is one that a lot of people don't reach in life. But again, we have to have the base and work our way up. So if you don't have safety and security, you won't have love and belonging. Okay. So again, it starts with the base and works its way up. Okay. As far as safety and security needs, that's huge for you guys as a CNA and when you go into healthcare, because many people are afraid of healthcare. They don't understand it, but with your education and your knowledge, you can relieve their anxieties and help them feel safe. You do that by asking them and explaining to them every task that you do. Even if it's as simple as a bath, the person should know why is it needed, who will do it, how will it be done, and what sensations or feelings the person might experience. Okay, that's on page 69 under safety and security needs. It talks about many people are afraid of healthcare. For every task, even a simple bath, the person should know. So know what you should do to relieve and make them feel safe and secure. You simply explain. It's harder to wacky ape. We explain it to you before we do it. Okay, now we're going to talk about culture and religion. Culture is the characteristics of a group of people or language, values, habits, likes, dislikes, and customs. Religion is spiritual beliefs. They are different, okay? Culture is passed on from one generation to the next generation. Culture, usually, like if you're Italian, you might have certain standards or certain things that your family believes in, where somebody who's from Europe or Polish or Irish might have different cultural beliefs. The Latinos have different cultural beliefs. And a lot of Indian cultures and Muslim cultures do as well. Okay. Religion has to do, the Indian cultures and Latino cultures, Italians, that's more or less the culture. And religion is more or less what religion you are and what the beliefs are. So are you Muslim? Are you Catholic? Are you Jewish? Are you Protestant? Are you Lutheran? There are many different cultures in spiritual beliefs. They might not always agree with what you believe in, but you have to respect the person again as a whole and understand their culture and their beliefs in their culture, or their practices may be different and strange to you, but you still respect them for it. And the same thing with the religion. A lot of people find strength and comfort in religion, especially when they're sick. So you might see them calling the clergy or asking for a pastor or praying more than what they usually would have when they were healthy. Never judge a person, never force your ideas on the person. And if they have certain cultural and religious practices that affect their care, that's going to be found in the care plan. So make sure you read your care plans if you're taking care of somebody who maybe has a cultural difference than you and you're not sure how to handle that. Okay. In your book, there's a lot about culture that I really, when we're in class, we really do spend some time talking about this. So as you can see on page 70 of your book, And caring about culture, healthcare beliefs, and sick care practices, the orange box. It talks about different cultures. It talks about the Mexican American culture, uses folk healers. They might use herbs and spices to prevent a cure disease. They might have a female doctor come in. They might have a male doctor or a male witch they call and come in. Um, and see the patient that's sick. And Russian Americans practice folk medicine too. There's herbs that they take for certain diseases. So if you can see, and I would just so you broaden your expansion or you broaden your horizons and you learn a little bit here, guys, I would really suggest that you read the orange boxes and understand how different some of the cultures can be. Okay, some cultures believe if it's a disease that is affecting the body, like temperature-wise and hot, they want to give cold for that. Okay, some believe it's a disease that's related to cold, they're going to give hot. So there's some very interesting stuff on page 70 in the orange box about caring about culture. Okay, what you do need to know definitely on page 70 is the focus on older persons orange box, where it says communicating with people who have dementia is often hard. And it talks about how do you address somebody with dementia? How do you get their attention? So focus on older persons. Make sure you read that, okay? And just know for culture and religion, you don't judge a person. You never force your own ideas, and you follow the care plans. Okay, communication is key in healthcare. So the next couple of things that we're going to talk about is communication. And there's going to be different ways to communicate. Some people will not have the same education level as you. Some people might have the same language as you. Some people might have a disability where they cannot understand communication as well. Some people might have dementia, which is a completely different way of communicating with somebody. So for effective communication between you and the person, you must follow the rules of communication. They are found on page 71 of your book. Here in the slides as well, it says that use words that have the same meaning for you and the person. Do not use big medical terms. Okay, even the word vowel movement or passing your vowels, they might not understand it. You might have to say, "Do you need to go to number 2? Do you need to go to the bathroom? Do you need to have a vowel movement?" They might not get that. You might have to say, "Do you need to poop?" They might say that to you. You might just say, "I need to take a poop. I need to take a crap." Okay, we don't use those words, but if they use them, that's okay. Another thing is you might, don't say afebrile. They don't understand what that means, or febrile. Febrile means fever. So just say you have a fever. Okay, afebrile means you're without a fever. Just so you could say your temperature is normal. You don't have a fever right now. Don't use big fancy words because they're not going to understand them. Okay, they don't have the medical terminology or the education to do that. Communicate in a logical and orderly manner. So explain what you're going to do and the steps that you're going to do it. Be organized when you speak. Give facts. Be brief and concise. Always respect the person for their rights to religion or culture. Repeat information. If you're not sure what they said, repeat it. Say, "I need to make sure I understand this. Can I repeat what you said? This is what I heard." Or ask them to repeat it. Okay? And always be patient. You have to understand some of these people they're elderly. Their mind doesn't move as quick as yours. Maybe they are tired. Maybe they're sick and weak and they just cannot process things as fast as you can. Or maybe they have dementia or some kind of psychological disorder where they don't really process things correctly. So be patient with them, be understanding, and listen as they speak. Okay, so in the blue box on page 71, use words that have the same meaning. Avoid medical terms. Make sure you highlight that you should give directions in an orderly manner. Give facts. Always respect the person. Be patient. Okay, verbal communication. So we're going to talk about verbal communication. Verbal communication can be verbal, can be written or spoken. Okay, so it could be me speaking like I am to now, or it could be written as well. Same thing with these things. When you're going to speak to somebody out of respect and to show dignity, face the person. Position yourself at their eye level. Control the loudness or tone of your voice. Don't be sarcastic. Don't be overly loud. Don't go too fast. Speak clearly, slowly, and distinctly. Pronunciate well. Okay? Make sure that you're watching them, that they are making facial expressions, that they understand you. Okay, no slang words, no vulgar words, no street words. Repeat the information. If they need it, repeat it. Don't get annoyed, repeat it. Ask one question at a time and wait for the person to answer you. You do not need to shout, whisper, or mumble. They will not hear you if you do those things. Make sure you're talking clear, concise, and slowly. Always be kind and courteous as well. Sometimes people cannot speak, or sometimes they can't read, or sometimes they just have a hard time following you. With those people, when you're communicating, do not give them long, complex questions to answer. Give them simple questions like, how do you feel today? Or another one is this water too hot? They'll say yes, or they'll say no. Okay, or is the water too cold? It's a yes or no answer. Okay, it could even be something as easy as, it's almost lunchtime. These are your choices: a turkey sandwich or pasta. Which one would you like? So again, he only has to pick from two things. Limit the answers and make the questions easy for them to answer. Okay, and you might have somebody who is deaf and they use sign language. You might have somebody who's very hard of hearing, and the best way to communicate with them is not verbally, but to write the words out. Okay, use a dry erase board. So we're going to go into your book and talk about some of those things. Under verbal communication on page 71, make sure you understand it's written and spoken words. And then these are the things that I highlighted. Make sure you face the person, that you're at eye level. Speak clearly, slowly, and distinctly. No slang words. Repeat as needed. Be kind and courteous. And then it says underneath there, under verbal communication on page 71, you use written word when the person cannot speak or hear but can read. So somebody might be hard of hearing, so they can't hear well, but they can read, so you can write to them. So the nursing care plan will tell you how to communicate with the person. There's different devices that are on page 72. A common one is a dry erase board that we use. We write things out on the dry erase board using a dark marker. And then this way we are explaining to the patient what we're doing, but she can't hear us well. So she could read, and she reads so she understands. It says on page 71, when writing messages, keep them simple and brief. So if you're going to write something out, keep that message simple and brief, okay? It might be as simple as, today is your shower day. Can we give you a shower today? It's a yes or no, okay? And then when she says yes, you could say, then I erase the dry erase board, put on there, what time would be good, 9 a.m. or 10 a.m.? Let her pick one. See how simple it is? Simple and concise is the key here, okay? It's always a good idea to use black ink when you're writing and print in large letters, because usually if they have a hearing problem, they might also have a vision problem. So you want to make sure they could read and understand what you're writing to them. Okay. Now we're going to talk about nonverbal communication. Nonverbal is when we do not use words. So we use gestures, facial expressions, posture, body movements. I personally think a nonverbal word is a stronger word than a verbal word, because your body and your body expressions show so much about you. You know, you could say something, but the way that your body expresses it really shows how you truly feel about it. So it says nonverbal communication does not use words. Gestures, facial expressions, posture, and body movement, touch, and smell are used. They are usually involuntary and hard to control. Okay, so when nonverbal, sometimes you just can't control it. I know I'm very, very bad at this. Like, I'll roll my eyes, I'll make facial expressions I shouldn't make. And it's just, that's my character, that's how I am. So sometimes I have to be careful about that. They're usually involuntary and hard to control. A person may say one thing but act on another way. So I might say something, or the patient might say something to you, but their nonverbal communication, the way they're acting, is communicating completely different. So they might say, no, I don't have any pain, I'm fine, but yet they're guarding their arm. And if you even come close to touching it, they're going to scream out. Okay, they do have pain, they're just not telling you. Okay, and then we're going to talk about touch. Touch is really important. Touch is a nonverbal communication. Touch conveys comfort, caring, loving, affection, interest, trust, concern, and reassurance. Make sure you know what trust does. Okay. So in your book, under touch, it says, touch is an important form of nonverbal communication. It conveys comforts, caring, and love. Make sure you know what touch conveys, okay? The meaning depends on the age, gender, experiences, and culture. So I might react differently to being touched than somebody else because I am older. I come from an Italian family where we're very loving and touchy, where I know like some cultures, it's not like that. Some cultures, it's not normal to run up and hug somebody. It's kind of taken back, okay? So you have to understand everybody has different feelings about touch. You can't force it on somebody, but you can offer it, and it's usually very well accepted. Body language. People send messages through their body language all the time, every single time. You guys are famous for this because you're teenagers and you're stuck in class with me, and I know you don't like it. And I know you're like, shut up. I don't want to talk. I don't want to hear you talk anymore. I don't want to lecture anymore. The eyes roll, the heads drop down. Some of you, I'm going to go to sleep. I'm dying over here. Okay, so again, facial expressions, gestures, posture, hand and body movements, your gaze, your eye contact, your eyes rolling or looking away as somebody's speaking to you. Okay, your appearance, you're sitting there with your hand on your hip and your eyes rolling like, oh, I just don't want to do this, or tapping your foot. All those actions, all that body language is telling people how you really feel. Your actions, movements, and facial expressions send messages. Also, the way you stand, sit, walk, and look at the person also send messages. Control your body language as much as possible. Okay, so you want to make sure you control that body language. We're going to talk about body language. It's on page 73 of your book. Okay. Control your reaction to odors from body fluids. So you walk in a room and it smells horribly. You can't be like, whoa, oh my God, and turn your nose up and make it, roll your eyes and be like, dude, what'd you eat today? You don't want to be like that. Okay, so you have to control your body. The patient's embarrassed by the body odor or what's going on with their body. They don't need you accelerating it and making it worse. Okay. You have to show them that you're interested. If you are not listening to them and looking at them while they're talking to you because you're looking away or you're more occupied on your phone or what's going on out in the hallway and you're not paying attention to your patients and having good eye contact and truly listening, that's noticeable because you're preoccupied. You're looking out to the hallway. You're tapping your foot. You're walking towards the door when she's still talking to you. Not good. All poor body language. Okay. Control your So if we go into the book for a little bit, on page 72, I want to go back to talking to you about touch. Caring about culture on page 72 in the orange box, you need to know this, guys. It's really important. When you do decide that you're going to use touch, you have to understand some cultures do not accept that, okay? And it should be on your care plan if it is a concern for your patients. So, for example, in India, men shake hands with other men, but not with women. For women, they place their palms together and bow slightly. As a sign of respect or to seek a blessing, people touch the feet of older adults. So in India, it's not okay for women to shake your hand. Okay, instead they put their hands together and they bow, and men shake hands. And they do touch the feet of the elderly out of respect. It also says people from China do not like being touched by strangers. A nod or a slight bow is given during introductions. Healthcare workers of the same gender are preferred if they're Asian. So if you are taking care of a female Asian elderly person or a female Asian, they prefer that their healthcare workers are female. Okay. In the Indian culture, it's very much like that too. When you're taking care of somebody, if it's the father or the grandfather, usually they want a woman from the family in the room. Okay, because they feel that their family related woman should be in the room when you're giving care. So again, these are all cultural things that you got to be aware of. And you'll learn as you go. I've learned a lot from working in my different areas that I worked at. Okay. Communication efforts are on page 73. Ways to communicate that are helpful. Okay, so on page 73. Before we go into that, I want to spend a little bit of time on page 73 in your book. Again, in the caring about culture, facial expressions. No, in America, these things happen all the time. Coldness. When somebody is mad at you, when they are pissed off, excuse my language, or they are cold and they are harsh and you know it, they give you that stare, that constant stare. It's in the box on page 73. If somebody's angry, usually their eyes are fixed in a hard stare, and the upper lids of the eyes are lowered down, like they're staring you down. Okay. Usually somebody's embarrassed, their eyes are turned away or down. The face is flushed. Make sure you know that. If somebody's embarrassed, they're not comfortable with something you're talking about, usually they'll look away. They'll turn their eyes down. Their face may be flushed or red. Okay. So, and disapproval or not feeling the vibe is usually the eyes are rolling. Okay. So, page 73, the orange box caring about culture. Know what somebody might look like if they're embarrassed, and know what somebody might look like if they are angry or have disapproval. Okay, and it also goes on to talk to you about Italian, Jewish, and African American, Hispanic persons are known to smile readily. They may use facial expressions and gestures for happiness, pain, or displeasure. So those cultures are very expressive. Okay. All right, communication methods. Listening. Listening is key in communicating. If you're just talk, and you don't listen, you're getting nowhere. You're not having effective communication. Make sure you're facing the person. You're giving good eye contact. You're leaning in towards them so they know you are truly listening and you're attentive. Respond to the person. Nod your head. Repeat what they say so they know you're staying with them in the conversation. Okay? Make sure you keep giving them feedback for the conversation. We already talked about direct questions. Those are questions that are yes or no or simple answers. Those are great to use. Open-ended questions can lead to a very long time at the bedside with your patient. Open-ended questions are basically you're telling the person, let's talk about it. Let's discuss how you feel. I want to know. So here's an example. A direct question would be like, what is your husband's name? And the patient responds, my husband's name is Vito. Okay. An open-ended question would be, can you tell me about your husband and your marriage? That could go on forever. The patient could start with, we got married in 1942, and then we had a kid in 1960 and then open-ended goes on forever. Okay. But it's good if you're trying to get somebody to express what's upsetting them or how they feel. Where direct questions are simple yes or no or one answer questions that get you to the point of what you need to know and get the action going. Okay, so that's the difference between direct and open questions. Make sure you know the yes or no is a direct question. Okay. Open-ended, it's going to be, you're going to be in the room a while. They're going to tell you a lot. So it has to do with their feelings. If you don't understand something, you clarify. Ask the person to repeat it, or you restate what they said. If a person's having a hard time staying focused and like you're talking to them about their breakfast and all of a sudden they start talking about all the favorite restaurants they like to eat at, you want to know, why didn't you just eat your breakfast this morning? But then they start talking about all the places they used to go to with their husband for breakfast. You need to know and get them focused on what was going on for this morning. So your original question was, why did you not eat breakfast this morning? Because they didn't eat it. And then they start going on, I'm not really much of a breakfast fan, but when my husband was alive, we used to go out to our favorite breakfast place. Well, and you're going to go on and on. So you're going to be like, you have to refocus the person. Say, wait, Mrs. Anderson, I love hearing about your stories about your husband and going out to breakfast, but I need to know now why you did not eat this morning. Okay, so you refocus them. And sometimes you don't have to say anything. Silence is a very powerful tool and very and a great way to communicate. Sometimes you just need to say nothing. Sometimes the person just needs to vent, and you just need to be there and listen. Okay. So in your book on page 73, know that listening, when you listen, you focus on what the person is saying. You're observing it for nonverbal cues. So you're watching and listening to what they're saying, but you're also watching their body language. Know that listening requires that you have care and you have interest in the patients. You should lean toward the patient, respond to the patients, sit eye level, and face the patients. Okay, all on page 73. All right, let's move along, guys. On page 74, again, there's an example of direct questions and open-ended questions. So here's an example of a direct question. Mr. Walker, do you want to shower this morning? It's a direct question. The answer is simple, yes or no. Okay, Mr. Walker, when would you like to do that? Again, it's simple. Yeah, he would say 10 o'clock, 9 o'clock. Okay. You could say, could we start in 15 minutes? I want to call he might say, can we start in 15 minutes? I need to call my son. Yes, I will be back in 15 minutes. I'll see you at 9:15. See, so it's very simple and direct. Yes, you could also ask him, Mr. Walker, did you have bowel movement today? Yes, I did. Mr. Walker, was it a normal bowel movement? Yes, it was. Okay, so simple yes and no answers or one-worded answers is a direct question. Open-ended questions are going to take a little bit longer. Okay, again, they're on page 74 of your book, explaining the two types of questions. Then clarifying and silence is also on there. I already talked to you about them. Silence is very powerful. Remember that. Caring about cultures on page 75. It talks about what do you do when somebody doesn't speak the same language as you. Okay, do the following when communicating with foreign speaking persons. Page 75 in the orange box. Convey comfort by your tone of voice and body language. Do not speak loudly. It's not that they can't hear you, they don't understand you. So speaking more loudly is not going to make them understand the English. Okay, speak slowly and distinctly. Be alert for words that they do know in your language so you can communicate with them easier. Use gestures, point at things, act things out, use pictures. Be alert if they're just nodding and saying yes, 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 which it does not seem that and that's all they're saying, but they're not understanding what you're telling them. That is not good. And then if you have a yes, ma'am situation, it's usually because they're not understanding you. Okay. And then also this focus on communication, page 75. We prefer that when we do have somebody who does not speak the same language as us, that we do not use family members to translate because that's a violation of HIPAA and Privacy Acts. So every hospital and nursing home has a list of people who are certified translators, or you can call an 800 number that your hospital or facility will have in place to get a translator on the phone. Okay, so it is not a good idea to use the cute little Spanish housekeeper who speaks, fluent, or cute little housekeeper who's in the hallway who moved here from Mexico and speaks fluent Spanish. No, because that's violating your patient's rights to privacy, and it's also running the risk of the person not being able to translate medically appropriately. Okay, so we have to call a translator. All right. So here are some of your communication barriers. We were just talking about unfamiliar language, cultural differences, changing the subject, giving options take a lot when others are silent, failure to listen. So these are things that if you're doing these, you're going to have a difficult time communicating with your patients. So communication barriers. They don't speak the same language as you. They have different cultural beliefs than you, and you don't understand those beliefs. If they change the subject while you're talking or they don't want to talk about it, it's usually because they're uncomfortable. Giving opinions. You don't give your opinions, okay? You're not there for that. You're there to educate and care for the person. Talking too much when others are silent, that means you're dominating the conversation, and that's not good communication. You need to listen to your person. You don't give pat answers. Pat answers are no. Pat answers are like, oh, it's going to be okay. Don't worry about it. I know you're upset now, but it'll be all better tomorrow. Okay. I know you couldn't walk today, but you know what? We'll get you there. Those pat answers just pacify people, and they're not appropriate. They're not truthful. Don't do that. Persons with disabilities on page 75. Understanding disability is any loss, absent, or impaired physical or mental function. Know how to talk to somebody that has a disability, disability etiquette on page 75, box 72. and know what to do if somebody's in a coma. So if your patient's in a coma too. So a person with a disability, just as I said, it's any loss or absent or impaired physical or mental function. It can be temporary or permanent. The person can acquire disability at any time in their life, be common or show common courtesies and manners applied to the person with disability. You treat them just as a normal person. You treat them with respect, dignity, courtesy, and manners. Do not hang or lean on a person's wheelchair if they're disabled. Do not pat the person on their head or the back of their shoulders if they're in a wheelchair. They're not a dog. Don't pat them. What you should do is you just sit or squat to talk to the person in a wheelchair or chair, so you're at their eye level and you're sitting or next to them so they can see you. Show the same courtesies as the person who you would anyone else. So don't treat them any differently. Make sure you show them the same respect and dignity and courtesies that you would show somebody who wasn't disabled. When somebody's in a coma, it means they're unable to respond to any stimuli. However, they often could still hear, and sometimes they could even see. So you have to treat the unconscious person like a conscious person, like a normal person. Okay. They can hear and they can feel touch and pain still. That's very common with them. So when caring for somebody who's in a coma or unconscious, assume that the person hears and understands you. So you still need to educate them. You still need to knock on the door. You still need to introduce yourself, even though they're in a coma. I know it sounds crazy. You still need to tell them what you're going to do and what they should expect. Okay. Use touch. Make sure you touch them gently and explain your care. And like I said before, knock. Introduce yourself. Try to keep the care that you give them on the same schedule every day because that helps them. So if they are comatose and maybe they start waking up from their coma, they might start putting the links together like, oh, at 8 a.m. they do oral care. At 9 o'clock, I get my bath. Okay, it just helps them when they do start to come out of the coma. It also helps sometimes even if they're in the coma so they understand a routine. Tell the person when you are finished giving care. Tell them when you're leaving the room. Okay, I know you're like, no, it's Bertels, they're unconscious, but still, okay, make sure you understand when you're leaving the room, you should tell them, thank you for the care. I hope you're comfortable. I'm leaving now. I'll be back in an hour to see how you're doing. Okay, so make sure you announce when you're leaving, when you're coming in, even though they're in a coma. I know it sounds crazy, but you still do it and watch their body language and facial expressions. Because in the coma, if they're in pain, they might not speak out, but you might see grimacing or like you might see tears coming from their eyes. Okay, so keep an eye on their nonverbal language. So disability etiquette, page 75, box 72. Make sure you highlight, show the same courtesies for somebody who has disability, touch or handle the person's wheelchair only with their consent, treat adults as adults, sit or squat next to the person, ask if help is needed for a disabled person. Never assume they need help. Sometimes they get offended if you just want to jump in and do everything for them. Instead of jumping in to do it all for them, ask them, how can I help you? What do you need help with? Okay, that shows respect and it shows that you're willing to work with them. Okay. All right. Family and friends. Family and friends affect the person's care in a good way or a positive way. And it can also be in a bad way. It just depends on what's going on in family dynamics. A lot of times family and friends and family help meet the basic needs. They help someone feel safe, secure, loved, and belonging. But sometimes they can also cause a lot of drama. The person has the right to visit with family and friends in private and without unnecessary interruptions. So if they say they want to have a visit and they don't want to be interrupted, you have to respect that. If you have to go in to give care, you might want to ask the family members to walk out and tell them where the waiting room is and then go back and get them from the waiting room when you're done. If they insist that they want to stay in, then you need to make sure that this patient consents to the family member being in there and do your best to protect their privacy as you're giving the care. Okay. But if you can get the patient's family and friends to step out of the room when you give care, that is just a lot easier. It avoids any violation of privacy. It also avoids any embarrassments. And sometimes it just gives family a break to get out of the room for a little bit. Okay, so know where your waiting rooms are and tell your family members to step out and go down there and you'll come and get them. Always report to the family members how well the care went while they were gone because they're just anxious and scared. Okay. Never, ever, we always know this already, never discuss the person's condition with family and friends. If they start asking you questions about what's going on with the patient or how the patient is, you just simply say, I'll get the nurse and she can speak to you. Okay, make sure you guys understand that. And then behavioral issues. We're done after this, guys. Behavioral issues. Sorry. Hold on. Okay. People are people. They have emotions. They have behaviors. They act out. And sometimes you have to understand that you've chosen a field where a lot can go on. The stress and anxiety levels can be very high. And people might lash out at you. But you have to understand it usually is just because they're fearful, they're in pain, they have anxiety, or they don't understand. Okay. Many patients, residents, families accept illness, injury, or disability and do well adjusting. Others might have the following behaviors. You might have the angry guy. Angry patients. Anger is very common, usually when people are afraid of fear, afraid of pain, are afraid of dying and death. Okay. Anger is shown verbally. They shout. They can be uncooperative. Anger can also be shown non-verbally by pasting a red face, clenched fists, getting close to you when speaking, like getting up in your face. Violent behaviors can occur. If you notice that a patient is getting angry or a family member is getting angry and it's escalating, make sure you have yourself in a safe area where you can get out, and make sure you get to the nurse and tell the nurse what's going on so she can address the behavior and make sure the patient and yourself are safe. The demanding patients. Oh, nothing seems to please a person. They're unhappy with all the care. They'll insult you. They'll be critical of you. Demanding because they just cannot handle the fact that they are dependent on people to take care of them. They've lost their independency. They lost their control of their life. They're getting sick and they can't control the sickness. So a lot of times the demanding person is just the unhappy person because of what's going on in their life. So they'll be demanding or disrespectful to you. Okay. The self-centered behavior patients. It's a person who thinks everybody should just take care of her. If you're taking care of another family, or if you're taking care of another patient and that this patient sees you, and maybe you're in the dining room and you're serving trays and your one patient needs to be fed. So the nurse tells you, you do the feeding, and then the nurse says, and I'll work on passing the trays. Okay, so you were directed by your nurse to do a feeding. So you're sitting down feeding a patient. But then Mr. Smith on the other side of the dining room starts screaming at you because he wants his oatmeal right now, and he wants his scrambled eggs right now. And why are you taking care of that patient when you should be giving me my stuff so I can eat? I'm going to have to wait all the time now because you're feeding somebody. I'm hungry now. Me. Okay, self-centered. Me. They don't care about others. It's all about them. The aggressive behavior is a person that will swear, bite, kick, punch, scratch, pinch. I don't know. I've spits. They will do all kinds of things when they're aggressive, and it's usually again because they have dementia. They're in pain, and you're touching them, and they don't know how to tell you that they're in pain, or they might be fearful or have anger. Okay, when somebody is an aggressive patient, make sure you report that to the nurse, and make sure you have help going into the room. Do never, ever approach an angry or aggressive person on your own, and never, ever argue with them. Okay, or pinch or hit them or bite them or spit back at them. That's not going to work. And then you have a withdrawal person. The person who withdraws is a person who does not want to be around others. They want to stay in their room. They don't want to participate in activities. They're very quiet. They spend time alone. They like to sit in dark, quiet rooms. And usually it's because they're just not feeling well, or they're not happy with what's going on, or maybe their disease is not progressing, or their healing is not happening. Okay. Then you have the inappropriate sexual behavior of patients. He'll make remarks at you. He might touch you in inappropriate ways. He might disrobe or masturbate right in front of you or in public areas. Sometimes these behaviors are not, they can be on purpose. I'm not going to lie. There are dirty, nasty people out there. But most of the time, these behaviors happen because the person has a neurological disorder. There might be coming off high or have some kind of drug side effects. They might have some confusion going on, or they might have dementia. Okay, so you have to understand it's not always sexually advancements that they're doing. Sometimes they're out of their mind and they don't realize what they're doing. But it will happen, and they are not pleasant behaviors, as the slide says. You can't avoid the person or lose control. So here's the thought. If the person's angry, if they're aggressive, if you start fighting back with them, you're in their boat. You're doing exactly what they're doing. Don't be that way. Sometimes just standing there and being quiet and agreeing with them. Yep, you're right. Okay. All right. I understand you're upset. Okay. All right. Okay. All right. Just keep saying it over and over to them. Okay. And say, all right, so this isn't going to work. And then make sure you get back to your nurse, tell your nurse what's going on. Recognize frustrating and frightening situations. So how are we going to deal with these people that have these behavioral problems, that are lashing out or angry? Think about what they feel like. Put yourself in their shoes. Recognize what may be frustrating them or what may be frightening them and change it. Okay? Every time I say I have to give Lydia a shower, she goes from the sweet little grandma to the wicked witch of the West, who starts spitting at me and throwing at me and biting and pinching me. Okay, let's figure this out. It's only when she goes to get a shower, so she obviously doesn't like a shower. So we're going to have to figure out what can we do to make her get in that shower and avoid these behaviors. Answer the questions clearly and thoroughly. Keep the person informed. Make sure you do your care in an accurate and concise way so they're not waiting forever for you. Explain why things might take longer. Always stay calm and professional, especially if they're angry or hostile or yelling at you. Don't argue with them. Just listen, use silence, and always protect yourself, and then get to your nurse. Okay, so those are on page 77, dealing with behavioral issues. Make sure you know that box, the blue box. Stay calm and professional. Do not argue with the person. Listen and use silence. All important things. Also on page 76, make sure you know what it is when somebody's withdrawn and when somebody is self-centered. Okay, those are behaviors that I talked to you about. And that's it. We're done.